I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, everyone, and welcome to the April 2016 PRS Journal Club. This is Raj Sawh-Martinez, and I'm joined as usual by my fellow resident ambassadors, Amanda Silva and Sammy, Sinno. This month, our special guest moderator is Dr. Janis, who is Vice Chair of Plastic Surgery at The Ohio State University, ASPS Board Vice President of Education, past President of ACAPS, and winner of numerous teaching awards. But most importantly, something we haven't heard about before is that Dr. Janis is actually the coach of some of the most winning teams of the PRS Residence Bowl. So before we get into this paper, you got to tell us, Dr. Janis, what's the winning secret?
Just believe in the residents, believe it or not. I know that having 4 teams now, 4 years, 2 teams who have won the Residence Bowl, I do get asked the question, are you giving your teams the answers? And quite honestly, I do not at all. So it's all resident performance and how brilliant the residents are and how they can perform under pressure. So I'm quite proud of them both in Dallas and in Columbus.
All right, nice. Well, we'll need to get some more insider tips next time too. Then,
just small bills, small unmarked bills. There's the tip. Don't eat yellow snow. Blue feather in the third. There's 2 more tips for you.
The check's in the mail. So in this section, we'll be discussing a study out of the University of Sao Paulo Medical School from Brazil entitled "Surgical Treatment of Facial Infantile Hemangiomas, an analysis that's based on tumor characteristics and outcomes." And just to let everyone listening know that there are, like all the other Journal Club articles, 2 paired articles that go along with this, as well as CME articles on this, so please check that out at PRSjournal.com. So in this study, Goldenberg et al. Sought to evaluate outcomes of surgical treatment that was based on tumor characteristics following an algorithmic approach. They reported the results between 1997 and 2010, where they evaluated 208 patients, with 41% of them having conservative follow-up, 23% having pharmacological therapy alone, either steroids or beta blockers, and the remaining 36% having surgical excision of their infantile hemangiomas. They described the indications for surgery as size, growth-related deformities, presence of ulceration, bleeding, or infection, and tumor characteristics and surgical approaches and outcomes were all characterized in the study. They reported having 74 patients in this study period who underwent 90 surgical procedures, and 85 of those patients ended up being female. Of the 74 who went surgical excision, 23% or 17 cases also had concurrent pharmacological treatment. They noted that 14 of these cases had a partial response and 2 were non-responsive to pharmacological treatment. However, they did not note if these failed therapies were from beta blockers or steroid therapy. The most common anatomical locations for the surgery were, as expected, lips, nose, eyelids, and cheeks. 20% of those reported cases, or 15 patients, noted to have hemangiomas that affected more than one anatomic subunit. Compromise of the visual axis was noted in 13% of their patients, and upper airway obstruction was noted in 3 patients, or 4%. Ulceration was noted in 15 patients, or 20% of the entire surgical treatment group. This study is an important evaluation of surgical cases at a referral center in Brazil for infantile hemangiomas, with very impressive surgical results and excellent clinical guidance on their surgical approaches. The authors describe their experience, and they note that the surgery remains the mainstay of treatment of infantile hemangiomas in the cervical facial area when they have an associated growth-related deformity that may be impairing adequate facial development. Since the advent of pharmacological therapy, I think the overall numbers of surgical excision of hemangiomas has decreased, or at least that's what it seems. However, I think it is important for us to understand the characteristics of the patient really well and know which ones will present with the need for surgical correction as they may become more refractory in cases as we become better with our pharmacological therapies. Ultimately, I think the study is limited in that it is a retrospective review. It does cross the era of the introduction of beta blocker therapy, and the clinical problem overall leads to limited sample size. But with that, I thought it was a very interesting paper, and I'd open it up to the group.
Well, that was a very thorough analysis, Raj. Great job. Good beat. You could dance to it. I'd give it an 89. So let's do this, okay? We're consistent with a couple of the other papers that we've discussed on other podcasts right now. Let's continue with the keep or trash philosophy. Again, for any new listeners that haven't yet heard the other two, which I would definitely go check out, no bias there. I would suggest that when you read a paper, you decide not tomorrow, not next week. When you put down that paper and you finish the conclusion, you should be able to decide whether you're going to keep that or whether you're going to trash it. And pretty much anything that you think is in between, you're just going to trash anyway because you're not going to read it. So let's go to you, Raj, first. Are you going to keep this paper or are you going to trash it?
This is probably one of the tougher ones, but
I'm sorry. For a second there, I thought you were talking. All we needed to hear was keep or trash. Keep or trash. That's the name of the game. Keep or trash.
Keep.
Keep. All right, Amanda, keep or trash?
Keep.
Keep. Sammy, keep or trash?
Keep.
Holy moly, we have got consent. This is the first paper that we have discussed that you guys actually agree with each other. All right, well, let's hear about it. Sammy, why are you keeping this paper?
Well, everything I know about hemangiomas is from essentially...
Which is zero, right? I'm sorry, go ahead.
Chapter 17.
Yeah, you've already disqualified anything that you're going to say after that. So. All right, Sammy.
So because of that, I think this paper is really well done, and I think Figure 1 is something that I'm going to be paying attention to a lot when it comes time for in-service and boards. I can definitely see that this is going to be a landmark paper for writing questions going forward. So for that simple reason, as selfish as it sounds, I'm going to keep it.
All right, Raj, I just heard the word landmark. That's more
that's
than
a big
keep.
word.
That's keep in bronze. Let's put it in a frame and post it on your wall. All right, Raj, what do you say? Why are you keeping it?
Yeah, landmark is a good word. It's an NYU word. I think for me, I think a lot of it has to do with just their approach, right? And I was most impressed truly by the results they had. Some of these hemangiomas in the pictures are, giant, and the results are pretty tremendous. So I think there's a lot of value here into how they're approaching their problem. Their numbers, I think, are a little bit higher than what I would expect currently. So I take this. That's why I personally had to, take the ultimate conclusions with a little bit of a grain of salt because the numbers are low and such a broad area. Perhaps some of these, I don't know when these pictures are from, right? Were these before beta blockade therapy? Could you have gotten a better result, with more adjuncts? Did they or did they not use laser? So I think there's some questions for me ultimately, but I do keep it because I think as hemangiomas, surgically treated hemangiomas become more rare, I think we're going to need more references like this that have, large numbers over multiple years with really tertiary care experience. And go through a way to think about the problem and figure out when is it okay to do surgery, when should we approach it, and how to think about that. And I agree with Sammy. I think that the early table with really all the diagnostic guidelines, size guidelines, I think that's going to be pretty impactful.
All right, so we've got landmark, we've got impactful. Amanda, batter up. What do you say?
Yeah.
You said keep. Is this a strong keep? What is this?
I would round out the consensus and say that definitely, especially Table 1 in the paper is a nice reference. I think that these authors have treated a lot of patients. They obviously have very good outcomes, and that it's an excellent reference for especially a resident trying to learn about this condition and understand the guidelines for when is it appropriate to go forward with surgery or not.
Wow. Orange whip, 3 orange whips, 5 bonus points and $10,000 for anybody who can name the movie. So I really think that it's, first of all, it's interesting that this is the first consensus. Second of all, really the value of this is through your eyes. You guys are the residents reading this, and whether it's in service or practically speaking, if you're treating these types of patients, it's valuable to hear your perspective. So let me turn the tables on you, okay? I've heard some pretty strong positive comments, but let's turn your reviewer eyes on since you have to read these with, a sense of constructive criticism as well. We'll go in reverse order. Amanda, name me the biggest limitation that you saw when you read the paper.
Well, I think that Raj already alluded to this, but the fact that it spans a long period of time and with a lot of new non-operative modalities such as beta blockade coming out to treat infantile hemangioma, I think that that definitely is a limitation to this study.
All right, so let's springboard off of that, Raj, because I heard you say that too, but let me push you off your rock here for a second. You take a look at those pictures of those little kids there at the end, and you tell me you're going to put those people on propranolol? The ones the ones that have visual access obscured, the ones that have huge deformities that could cause problems with breathing?
Right, yeah, no, and obviously the answer is absolutely not. And my point on the propranolol is, if these were taking in the time before that existed, maybe they were waiting clinically before they got to the size, before there was this big ulcerated mass and on this kid's face and eye. Were they waiting for involution? Were they waiting to see if it was going to, anything was going to change and then, undergo surgery? Or if we had beta blockers when it was a smaller lesion, would they start therapy earlier, have that regress potentially, and then either excise it once it's fully involuted, or not even need anything because it's gone away? So no, of course, at the stage here when there, these large, masses and they are affecting function, then no, I think that there's only one answer. You need to take him to surgery. And as the authors point out, some of these cases they call it emergent surgeries. In my head,
I think they said it was emergential or something. I'm not sure I've ever seen that word. Is that a word? What is emergential? I want 5 slides on that word, Raj. Send it to me when we're done.
Yeah,
Sammy.
I agree with the point that Amanda made, but also too, I know that these deformities aren't very common, but 74 patients over such a large period of time is something that I would like to see more if it was a multi-institute or multi-center study, just to see larger numbers of patients. But I really think valiant effort. I haven't seen many of these patients in my training, and I'm sure these are very, very challenging situations to deal with. I really congratulate their results. They seem pretty amazing to me.
I think Sammy's running for president here for a second. So I agree with all of you guys. I really like this paper, and full disclosure, I don't treat this patient population myself and haven't since I was a resident, but I really read this with great interest. That being said, again, as a critical reviewer, so to speak, let's discuss a couple of things maybe that I saw. In the section where it outlined how the reviewers were going to categorize this, basically surgical difficulty, easy, medium, or high, facial contour, worsening, slight improvement, great improvement, volume reduction, worsening, slight, or great, need for reoperation. That's probably a little bit cleaner. I know that there was a good inter-observer agreement, but I personally would have liked to have seen some predefined criteria, at least, that were listed around these questions of difficulty and contour and reduction. I think that would have just made it even more clear, but again, when I was reading it, I thought that came to mind. I wanted to draw your attention there was a sentence that said the indication is focused on cases with growth-related deformities and removal of the tumor potentially would allow facial development. In other words, it's telling you exactly when you would when surgery would be indicated, growth-related deformities, and when removal of the tumor would allow for facial development. And I think that's an important point. I also wanted to point out that they had some very nice references that included psychosocial problems that this patient subpopulation encounters. Those are references 9 and 34. And I think that, if you're going to be familiar with this paper, you might as well be familiar with those as well. I think the most important take-home point, and again, I'm reading a PDF, so I can't draw the reader's attention to maybe the final article, but there is a paragraph that begins the judicious selection, and then in it, I'm going to read this to you because I really thought this was the most important thing. A clinical profile of candidates for surgery was defined. Under elective circumstances, patients with proliferative localized eyelid, nasal, or lip hemangiomas with growth-related deformities are best candidates for total resection under direct or indirect approach. For patients treated as emergency indication, the best candidates are those non-responders to pharmacological therapy, presenting complications with segmental lesions, treated by partial resection under direct approach, and it references Figure 1. So while you're looking at Figure 1, I was originally looking at the verbiage that supports that, and basically I would agree with all of you that Figure 1 is definitely something to pay attention to, and that is what I thought the take-home of this experience was, this article. So, it's interesting. Again, these three articles that we've discussed, can be discussed together or can be discussed individually, but this is definitely a keeper in my book as well.
Awesome. Well, thank you so much, Dr. Janis. Thanks, everyone, for all the comments and questions, and that'll wrap up this Journal Club for April 2016. Thanks so much.
Sounds great.
Thank you.
Thank you.
Thank you.